that please don't give any of your life stories, or you might find it's broadcast more widely than you want. Men's health, all health is really important. Richard and I, and the public health, plus all the people that support the NHS, spend much of our time looking at various aspects of health. And without wishing to stereotype men, my experience over a number of years in general practice is men tend to present later. They tend to minimize their symptoms and conditions, and sometimes are persuaded to come in rather than come in voluntarily. So always my antennae used to go up when a couple came in and it was the consultation for a male, and the first question, not only what was it about, but to try and find the dynamics of what was going. So when you look at the various conditions that we're going to talk about briefly today, part of the importance of this Men's Health Week is not only to raise the profile, but try to encourage men to come forward earlier and seek help. Even if you look at some of the screening programs, and Richard will talk, I'll talk to him a bit about this later, the uptake in men is often, in particular age groups, less than it is with women. So can we go to the next slide, please? So we've introduced ourselves, and we'll talk about a number of conditions, but also some general stuff about cancer. So next slide, please. So we were going to cover something about the symptoms and signs of cancer, and when to speak to your GP. As an NHS, we're looking to diagnose people earlier. And it's interesting to know that when you look at people who present in the early stage of the disease, it's not a rocket scientist to work out that the survival will be much better the earlier we can detect it. And some cancers present late for various reasons, but at the moment, only about 55% of cancers are diagnosed in what we call stage 1 and 2. More are diagnosed in stage 3 and 4. But if we got 75% at stage 1 or 2, we would save about 55,000 more lives a year. And that's the NHS ambition. So early diagnosis is clearly important. We'll talk a bit more about bowel screening and prostate cancer. And then Sue's going to lead some discussions on communities against cancer and the opportunities more for people who listen to this webinar now or afterwards can get involved. Next slide, please. So Richard, do you want to just talk us through some of your experiences as a GP of the common signs that people not only present with, but the ones that people perhaps come in with, but don't really think they've got, they don't come in with this high degree of suspicion that they've got cancer?
Yeah, and there are some very obvious ones that I think people are more forthcoming with, and those are the sort of the unexpected lumps. So we see a lot of ladies presenting with breast lumps. We see gentlemen who might have noticed lumps in armpits or around the neck, particularly with enlarged lymph nodes. But some of these more vague symptoms, which actually we probably don't see as early as we could. And on this slide, they've listed quite a few of those. So sudden or unexpected weight loss that you can't explain. So if you've suddenly taken up marathon running and changed your diet, that might explain weight loss. But actually, if it's just happened, it could be a sign of something serious going on underneath the surface. Again, fatigue, loss of appetite, very vague symptoms that don't necessarily point to anything in particular, but could be a cause of any number of cancers. The persistent cough is a very pertinent one at the moment with COVID, although if you're big news hounds, you'll see that the Delta variant has less cough and appears more like hay fever. But certainly a persistent cough of 3 weeks or more, the GP team certainly wants to hear from you. And I think probably blood in your pee or your stools, generally people would sit up and notice, but sometimes do nothing. And metaphorically speaking, it's not something you should sit on.
So this 50-year-old male comes into your surgery and says, Dr. Roope, I'm losing weight. So what does that sieve that goes through your brain, what are you thinking of what could cause the unexpected weight loss?
Well, I think the cancer is the first alarm bell because it's the one that you need to get on top of as quickly as possible, if that's what it is. But even with quite a dramatic symptom like that, it's only going to be a small minority of patients who do actually have an underlying cancer. There are lots of other reasons, non-cancerous reasons, both in the physical and also in the mental health domain. Quite often with depression, people will lose weight. So it's something that we as GPs and our teams are really keen to explore and do a deep dive to find out what's going on.
Yeah, it was always diabetes and cancer sort of immediately came to mind. So, you know, are you thirsty? And then, you know, have you got any other symptoms? Okay, so these are things which people should take seriously, and I absolutely agree with you. You know, people will give reasons, either justify to themselves or to their family, as to why some of the things would happen. But I think in any of those symptoms, if people have got those, they should be presenting to general practice, maybe, you know, to the GP, but we've obviously got a broader team now. So when people have those symptoms or they're concerned about that, what would you suggest they make an appointment to see their GP? You know, the various mechanisms we've got at the moment where you can contact your GP, which is not just a face-to-face.
Yeah, so most practices will have a system in place. For a lot of practices, that's either the first approach is by telephone or by email through the e-consult system. And then that would be assessed by a clinician who would then contact you through the most convenient and most appropriate way. And where it's felt appropriate, we would certainly bring you into the surgery so that we could lay a hand on whichever body part is out of kilter. And then on the basis of that, we may then engage and do more investigations, more blood tests, etc.
And I think the next bit about how long you've had the symptoms is really important, because, you know, the human body is an amazing thing, but, you know, there are disturbances in the body which happen for a short period of time and settle, versus, you know, if you've had a change in bowel habit for 24 hours, there are multiple things can do that. Whereas if you've had a change in bowel habit that's gone on for weeks, then, you know, that would cause us greater concern. Would you agree with that?
Yeah, absolutely. And there are some things that you probably need to take action immediately. So, for instance, the weight loss that you've lost 5 or 6 kilograms or maybe a stone, you clearly need to get on with that because that's been going on for a while anyway. Likewise, if you notice a dodgy mole that's changed, don't wait another 3 weeks, get onto your GP immediately. But I think for new symptoms that are pitched up, so maybe a change in bowel pattern, just see if that settles, because it might be a contaminated barbecue or something that's giving you a bit of the trots. But normally speaking, with those sort of symptoms, we would say if things haven't settled within about 3 weeks, it's time for action.
And I think the skin bit's quite important, isn't it? Because certainly in my experience where I've worked, we've got a high elderly population. Used to see quite a lot of men with skin cancers who did national service, were abroad and exposed their skin at a fairly young age for fairly prolonged periods to the sun at a time when probably there wasn't such thing as sun cream, etc. So yeah, I agree. If you've got a mole or something that changes or something that's growing rapidly, then we would want to be in contact with you and potentially see you.
Yeah, the melanoma one is a really interesting thing because the incidence is actually almost identical between men and women, but men do worse because they don't pitch up to their GP as quick as the ladies do. So there's quite a marked inequality in terms of deaths from melanoma because men are presenting later than the women.
Okay, that's interesting. And so you go and see your GP, and, you know, clearly we'd be interested in what medication, because medication can cause quite a lot of symptoms. And then we'd carry out tests. What sort of tests would you normally do?
So depending on the exact symptoms, it's likely to be blood tests, but may also involve a chest X-ray and possibly a scan, an ultrasound scan, if that's felt to be appropriate, particularly if it looks as though there might be something going on in the abdomen.
Yeah, the other thing I would highlight is, and I think young men do present with this, is testicular lumps. So testicular cancer is more common in people in their 20s, the younger age group. So not uncommonly, young men will present with lumps and there are 2 very distinct forms of cancer that we see. So picking that up early and treat it there's a high cure rate. Again, agree with that, Richard?
Yeah, totally. And testicular cancer has one of the highest survival rates, but really important to catch it early because it's obviously the testicle is a relatively external structure. Generally, it does present quite early, but certainly if any gents do notice something that is different to what it would normally be in that zone, we want to hear from you.
Okay, next slide, please. So some time ago, to get faster diagnosis, you can read in the paper that somebody went to their GP 7 times before they were eventually referred. I think the media is not always terribly fair to GPs. If people present with bleeding from their back passage, losing weight, to change in bowel habit, probably most of the people watching this webinar could suspect that somebody might have bowel cancer. But often people do present with more vague symptoms. And then, as Richard says, well, not only will we take a history, examine, do some tests, and those tests may lead on, and there's often a delay between one test and another test until we get to a diagnosis. So some years ago, they introduced this 2-week wait, where for specific symptoms, we can then, what was now called fast track people in. So just explain, Richard, how that works in your practice.
So if patients present with a problem and with the test that we've got, if they reach certain criteria, then we refer down this pathway, and it guarantees that you will be assessed by our hospital colleagues within 2 weeks of the date of referral. Interestingly, the system is just about to go through a slight change where we're now moving towards something called the faster diagnosis standard, which is where cancer will be ruled in or out within 28 days of you presenting to your GP and that referral being made. And that should actually speed things up and hopefully contribute to this target of reaching 75% of cancers being diagnosed at early stage by 2028.
So that's really important and really useful for GPs who have an index of suspicion. But it's probably worth pointing out that locally, only about 8% of those referred through the system end up with being diagnosed with a cancer. So these are people we might suspect, but we're not absolutely certain. So really useful service that's available.
Yeah, and one of the best ways of perhaps phrasing the service is that it's a service to rule out cancer. And as Nigel mentions, the vast majority of patients we do refer, there's another less concerning cause.
Next slide, please. So the benefits of early diagnosis. Well, I think it probably goes without saying that we said a bit earlier that if we can get things earlier, we will get better survival rates. If you pick things up before they've spread, then it gives us more treatment options, whether that might be surgery, even chemotherapy or radiotherapy. The earlier the stage, the more likely we'll be successful, and we can use the different cancers will respond to different treatments. It's not a universal everyone has surgery or everyone has chemotherapy. Also, hopefully the earlier you catch it, the less impact the treatment's going to have on people's quality of life. And the cancer specialists in the hospital have then got a better range of options that they can use. And if we use less invasive surgery, or we don't have to go in with the really powerful chemotherapeutic agents, then recovery becomes quicker. So early diagnosis, really important. Again, Richard, any other comments to make about that?
Yeah, and it's when you sort of look at the benefits, you can sort of almost be quite structured with the benefits that we see. So there are clear benefits to the patients. And even if you have the misfortune to present with a quite advanced cancer, by it being diagnosed earlier, your general health will not have declined as much, which then means you're fit enough to have perhaps those more challenging treatments. Whereas if you've become quite frail and lost weight and lost condition, those options may not be suitable because of the impact they will have on the person. Obviously, from the doctor's point of view, we're always keen to diagnose earlier because we like to make a difference. I like our patients to be healthy and well, but also from the wider system, an earlier cancer is less expensive on both resources and time to the whole NHS system. So it's a win-win-win. Patients do better, doctors get much more professional satisfaction at helping you along the way, and it costs the system less money and uses up less resources.
And actually, there's a really important point you make about sort of pre-treatment health. So, you know, even with routine surgery, let alone cancer surgery, we would strongly encourage people to look at their diet and their general state of fitness, because the healthier you are in terms of, you know, what you're eating and put into your body, but also your level of fitness means that if you need surgery, for example, you're more likely to do better as a result of it. So it's not just what we can do for you, it's what you can do for yourself as well.
Yeah. And we've developed this probably new word that probably really doesn't exist, but it's called prehabilitation. So it's getting you fitter before you engage in a treatment that might otherwise be quite challenging.
Okay, next slide, please. Okay, so screening for bowel cancer. So this was introduced some years ago. Bowel cancer is one of what we call the big four. So bowel, prostate, breast and lung are the four cancers which are most common and most likely to have impact on us. And bowel screening was introduced to try and reduce the number of people who had early signs which would then go on to become cancerous. Just about to extend it, it was people would get screening from 60 to 74, now going to be from 56 to 74. Richard, what's your experience of the screening program and the benefits that it's provided?
So huge benefits. It allows both very early cancers to be found, but actually, as important, we can actually find things called adenomas, which are precancerous. So it actually can prevent cancers from even starting. And what we know, as Nigel mentioned in the little preamble, men do not engage in the same numbers as women do. I think women are familiar with their cervical screening. They're probably better at dealing with more intimate subject matters, but the men are a bit sheepish and don't come forward in such numbers.
And I think when in the, you know, the old tests used to have to give 3 tests, what we called fecal occult bloods. And again, that was seen as being a bit messy and horrible. So people didn't do it. With the new tests, the FIT test is very simple to do and much easier and should be more acceptable. So we really should be encouraging men to do this. I mean, I think the figures, and correct me if I'm wrong, Richard, that we pick up about 2% are positive on this. And of those that we then go on to do a colonoscope where we look with the endoscopy around the bowel, we pick up about 10% of those have potentially got cancers. So, you know, the numbers are relatively small, but it is saving a not insignificant number of lives per year.
Yeah. Certainly lives are being saved, and the data of the adenomas is not as well captured, but there will be folk who are found to have these adenomas, and then they would go into a regular surveillance program, and in many cases they will have a cancer prevented that they never knew they would have got.
So we'd quite like the people here who are watching the webinar, who are coming from the men's sheds and various other groups, that if we've convinced you of what we're saying, that you can promote that in your groups to encourage people to partake in it. It really is quite easy to do, but it's quite easy for people to put it off. You know, the kit is sent through in the post and people put it on the side. Oh, I'll come and do that. Oh, I'm not sure I really want to do that. And if I find something, I don't really want an endoscopy. But it really is not only important, but it can make a real difference. And if people then change their mind and they don't have the kit, you can contact the bowel screening service, which you can just Google, and you can find a number where you can get another kit delivered. Okay, so screening for bowel cancer, really important that we increase the uptake in men. And Richard's absolutely right. I sort of seen in my practice, the uptake between men and women, there is a 10 or 15% difference of uptake. Right, next slide, please. Right, prostate cancer. So this is the sort of big one for men. So Richard, I know you're an expert in this area. So what messages would you like to give to men about prostate cancer?
I think it's take notice of your sort of bladder function. This really quite stark statistic that for those of us born since 1960, we have a 1 in 6 lifetime chance of developing prostate cancer at some stage. And for our Black male colleagues and friends and family, it's a staggering 1 in 3 lifetime risk. So it's double the risk of white men. Interestingly, for Asian men, it's actually half the risk of white men. And this is almost certainly a genetic phenomenon. It's hardwired into our genes. There may be some other sort of lifestyle and societal influences, but it's largely thought to be genetic. And if you do have urinary symptoms that have changed and you're over the age of sort of 45, certainly for Black men, and probably 50 for white men, it's worth having a chat with your GP team to see what can be done. And almost certainly, if you do have urinary symptoms, we will be arranging a PSA test.
So why don't we screen for this, Richard? Why don't we do PSAs on all males over 50 every year? Is that a good idea?
Not particularly. And the challenge we've got is that it is a PSA test and not a PCSA test. So it's a prostate-specific antigen, not a prostate cancer-specific antigen. And unfortunately, the PSA can be elevated for a number of different reasons. And probably the commonest is just the standard slight enlargement of the prostate gland that we gents all get as we mature. So PSA screening has been looked at in great detail, not only in the UK, but in a lot of developed countries. And the screening has been shown not to make any difference to outcomes.
So you then go to potentially screening Black men, or not screening, but having a higher index of suspicion, and,
yeah.
and as GPs, if people come in with, getting up at night 2 or 3 times, or hesitancy, or poor screen, then we'd do a PSA and look for prostate cancer.
Yeah, and also I would add into that list any sort of erectile dysfunction problems. That can also sometimes be the first sign of something going on in the prostate gland.
And treatment for that, again, if we catch it early, the outcomes can be quite good if they're caught early. Yeah.
Again, it's one of the highest surviving cancers. So a really significant number of men diagnosed with prostate cancer will still be with us 10 years after diagnosis. One of the challenges we have with prostate cancer is it's probably, well, definitely not one condition. There are subgroups ranging from the very aggressive that we tend to see in younger males, and that can be really quite drastic and quite a challenge for the medical world. And then right at the other end of the spectrum, there are prostate cancer cells that sit there, really don't do anything, don't develop. And we medics have a rather stark, but nonetheless true saying that a lot of men with that type of prostate cancer will die with it and not from it. So you will succumb to something else before the prostate cancer causes any trouble.
I think I remember being told as a medical student that if we reached the age of 100, we would, as males, we'd all have prostate cancer, but it would more likely be the sort that you're talking about. And I think it is interesting, in my experience as a GP, is that you can see some people get very advanced aggressive disease early, and others it's a much more benign path, which then makes it difficult for the oncologists in terms of treating it. And I know some of my patients got a bit perplexed when the advice from the oncologist was that we would keep the monitoring rather than doing any intervention, because it didn't seem to be, the cancer didn't seem to be changing very much. Yeah.
And one of the things that has changed over the last year or so, which makes a huge difference, is the initial workup for prostate cancer no longer involves biopsies. And it used to be that the biopsies were actually done through the rectum, through the back passage, which sounded absolutely horrendous, and actually medically had some risks associated with it, because you were essentially sticking a needle through a fairly dirty part of the anatomy into what was a very clean part of the anatomy, and sometimes there would be quite nasty infections. But that's all pretty much gone, and the assessment is now done with an MRI scan.
And I think that's really important, because I know I've had some men in the past who've talked to their friends who've had the test and actually have declined being referred because they didn't want to have the biopsy. So I think that's really important. Okay, can we move on to the next slide, please? So we've got 5 minutes or so before we hand over to Sue. Does anybody, I don't think there are any questions in the chat bar. Have any of the people on the webinar got any questions or any areas that they'd like Richard or I to comment on? No? In which case, is there anything else you'd like to say, Richard, before we hand over to Sue?
Yeah, and I think just we talked about the 10-year survival. That's currently at about 78 to 80% of folk diagnosed with prostate cancer will live for at least 10 years. And in many situations, that suggests that they will eventually succumb to something else, going back to what we talked about, living with the cancer rather than dying from it. And really important that if you do have those lower urinary tract symptoms, as we call them, say a reduced flow, or having to get up frequently at night, or finding when you want to go, you have to go very quickly, or erectile dysfunction, we really want to see you in the practices so that we can assess, and hopefully, if there is something there, make a diagnosis at an early stage.
Yeah, and I think some of the things I found quite interesting in working in the Cancer Alliance is, for example, 40% of cancers are preventable. And when you look at that, smoking is the biggest one. And we know that the smoking rates are going down in men. But I think we're seeing more cancers in women that are smoking related. As you look at the difference between smoking in males and females. Also, it is, even as a GP, trying to keep up to date with everything. We recently were discussing lung cancer, and the treatments for lung cancer have changed quite significantly. So, and the outlooks are better in many areas than they were before. So, the living with or surviving cancer rather than, cancer always has got one endpoint is really important for people to be positive and, be objective about what is available to help and support them and manage them.
Yeah, I think really important. And we've sort of got a two-sided coin. The depressing side of the coin is that at least 50% of us will develop one or more cancers in our lifetime, for those of us born since 1960. But the optimistic side of that same coin is that well over half of those patients will be cured from that cancer. So it's no longer the death sentence that certainly when I started my medical career, we just thought that cancer, if you got cancer, that was you're stuffed and you'll die from it. But actually well over 50% now will be cured from it. And interestingly, although it's not a particularly savory thing to linger on, but having had one cancer, it does actually put you at slightly more risk of developing a second cancer. And I've certainly got sort of 3 or 4 patients who are now on their third cancer and are now used to surviving their cancer.
Yeah, the other thing I would note in my I became a GP in 1987 is we saw lots of, particularly men, die in their 50s of cardiovascular, of heart disease, had out of the blue, had heart attacks or developed heart failure or in their early 60s strokes. And over a period of time, not only with the reduction in smoking, but also with better treatments, people are no longer dying in that age group so frequently. So they live longer. And if you look at the incidence of cancer, it's particularly, more people will get it in the older age group, obviously. So that's one of the reasons we're seeing more cancer. But I agree entirely. Natalie's asked a question about, do you have to wait for an invitation for screening, or can you get a fit test earlier? You can't get a fit test, is my understanding, Richard, below the age of 60, now 56. But if you're in that age group between 56 and 70, is it 74 or 70? I see the slide say 74. I had it in my mind it was 70. But
so I think it's 74, but actually you can keep asking for one.
Right, beyond that, okay.
One of those optional.
Yeah, if you're in that age group, you can ask for it. Okay, any other questions, or shall we hand over to Sue? So if we can go to the next slide, please, and then we'll...
Thank you very much, Nigel and Richard. I'm not a clinical person, so I always learn a lot from listening to colleagues who are part of the Alliance. So again, I've learned a lot, and I'm involved in some work that I'll explain about engaging with Black men around some of the barriers they experience around prostate cancer. So I'll talk about that opportunity in a moment, but lots of what you've said is pertinent in terms of taking it forward and having conversations with people. So thank you. What I will cover just now is there is so much going on with the Wessex Cancer Alliance and cancer services. There are so many opportunities for people, whether they've been a patient or a carer or somebody else affected by cancer through, a loved one or friends or family. There are opportunities for people to get involved. And like Nigel and Richard said, as well as not necessarily coming forward to seeking access to services and getting help from their GP, it's also quite often more difficult to encourage men to come forward to shape some of these services. So it would be great if you could help us promote these opportunities so more men do get involved. Natalie, could I ask you to move the next slide? The Cancer Alliance is a partnership of all sorts of organisations. The Wessex Cancer Alliance involves GPs like Nigel and Richard, but also people who buy services, other organisations like our own. I work in the voluntary sector, Macmillan, CR UK, Cancer Research UK. There's a whole range of people that are involved in trying to improve and innovate around cancer services. And so our involvement network is an opportunity to shape the work of the Alliance. And I've worked for a small project called Wessex Voices, and it's our job to support the Alliance to involve people. So as I've said, anyone who's affected by cancer can get involved. Our involvement network has people from a huge, diverse range of backgrounds, and we look to increase that. We cover a big geography, so we cover Dorset, Hampshire and Isle of Wight. So again, there's opportunities for people who live in the conurbations or people who live remotely to shape the services according to their geography, but also who they are, whether they're from a minority ethnic community or affected by disability of other forms, or anyone really in our population who can get involved. And we have volunteers who really want to be actively involved in the start of projects, to those who just want to keep in touch with us and hear what's going on. And we have a newsletter that goes out regularly, and people can move between those according to what's going on in their life. Quite often cancer patients may be going through treatment, and so may want to step back at times, or may have other family commitments that of course mean that they can't get as actively involved as they'd like. So they may want to just move away slightly from some of the projects they've been involved with, and when they feel like it, can come back. And we try very much to make sure that people are involved in the way that suits them. So there's no pressure for people to get involved, but to do it in the way that really works well with their life, really. There are different work streams. Today has been particularly focused on making sure people come forward to get as early a diagnosis as possible. And Richard and Nigel talked about getting faster diagnosis, but the Alliance also look at people's experience of treatment and making sure that that works well for them as individuals, and the care that they also get, making sure that that suits them. And I'll talk about a couple of projects that are in that space that people can get involved with. Well, excuse me, my hay fever is beginning to affect the voice. Could I ask you to move on again, please? Thank you. So how does our involvement network work? Wessex Voices, we have a small project team that support the network, but also support the individuals that want to get involved in that network. So our volunteers, we make sure that they are involved in ways that they want to, that they can claim their expenses in a timely way, that they're clear about why they want to get involved, and also what the projects are that they are getting involved. And if there's any issues with the projects that they do get involved with, they can come to us as an independent project and share their concerns and give us feedback, and we can work with the Alliance to make things even better. We work with Alliance colleagues to get them to say, how are they going to involve people very early in their projects? Because obviously we feel that people need to be involved in the start. So those projects and initiatives are very much informed from people from the outset. And we work with the Alliance team to make sure that they're doing that well. Sometimes colleagues, I always suggest that they think about how they're going to communicate what they want to involve people in by saying, how would you describe this to your mum, your dad, your brother, your sister, in a way so people can understand it? Because people in the system can quite often get involved very heavily and passionately, and sometimes language might be one of the things that excludes individuals from getting involved. So we try and make sure that everything they put out is very clear and is done in a timely and meaningful way. In terms of the opportunities, I've said that it's really important that people know what they're getting involved with. What is the time commitment for them? What will they be expected to do? And making sure that they understand those commitments, so everyone's expectations are met, and that all of the processes that they get involved with are really clear to them and are really positive, really. So we want people to enjoy, have fun in terms of what they get involved with, and really feel like they can make a difference, because that's so key and important. And of course, the most important bit is that people understand what has changed as a result of their involvement. Where have they made a difference? How have they changed things for the better for others? And that's quite often people's motivation for getting involved in different projects. How can people make a difference? And we share the stories that our volunteers get involved with, because it's always insightful to hear actually what have they got out of the opportunity to get involved. Could I ask you to move on, please, Natalie? Some of the types of projects that are around at the moment, the work that has been described around prostate cancer for Black men, we've got groups of men that have been meeting sort of regularly and telling us actually about some of their experience. And it's been quite humbling, because those that have got involved have quite often lost a loved one, a family member, their brother, their dad, their uncle to prostate cancer earlier, because they didn't go and get tested, having a PSA test. And it's actually quite surprising to still hear that they're still reluctant to go and get tests. And I think some of their reluctance would be borne out in the whole population. So actually, if we make it better for one group of people, we can make it better for all men. So there's that piece of work that's going on at the moment. There are other bits of work that's about making sure that people get the right kind of support earlier in their cancer journey. So at the point at which they are diagnosed, people often tell us there's a gap there. They don't know where to go for information and support in that period. And also after they've finished their treatment, they're quite often, once they're sort of handed over in terms of their hospital team, and they've left the sort of support that they've very intensively had in hospital, that they need support at that point. So there's a project called Right by You. It's being piloted in the Southampton and Dorset area, but eventually the intention is that it will be across the whole of the area. And that's about how people can get involved to shape what that support looks like, and how people can plan for that with their clinical colleagues. So how do patients their loved ones get the right support at the right time for them. And there's other pieces of innovation work that are going on around how people can get better advice around their diet and nutrition. And we've got an event on Tuesday that's about patients telling the dietitians in a couple of hospitals locally about where they would like information and advice given to them, at what point, what would be helpful in what way. So there's lots of different initiatives that are going on at the moment, and we have a newsletter and a website, which I'll ask Gemma if she's kindly there to put a link in our chat so you can have a look there, so you can see the whole range of opportunities. There's another exciting project called Communities Against Cancer. And if there are groups that you're involved with who experience health inequalities in our local area, there's opportunities to bid for or put in an application for small grants of up to £5,000 to do work with your community group along the south coast of Hampshire and Isle of Wight and Dorset, to create initiatives that's around raising awareness of cancer for your communities. The Communities Against Cancer team also do some training, so a bit like today, but more general, about signs and symptoms of cancer. And there's a whole range of events that are taking place locally, and I'll post a little link to that in the chat box as well. There's some dates coming up for our local area in the next month or two, and the team regularly run those training events. So if people haven't been able to come today and you think they're interested, they may wish to get involved in one of those training events. But we've really encouraged groups and for you to share information with others about the opportunity to get involved with applying for a small grant to do your own activities with your constituents and members and contacts, to really do something that's applicable to your little group or large organisation. It doesn't matter which, you can be an individual that applies for that too. In terms of other opportunities, again, we promote these through our newsletter, and it may be that we're asked for feedback through different surveys, or to help shape surveys, to help shape leaflets, to help shape our websites. We've got two websites. One is the Wessex Cancer Alliance website, but there's also the Cancer Matters website that was shown on Nigel's and Richard's slides earlier. And again, there's an opportunity to make sure that they're right for people. So it's definitely worth having a look at for those. And if you've got feedback, we'd be very happy to take that too. Eventually, in the next few months, we would like to create an accountability group. So made up of patients, the public and organisations, to really help shape how the Alliance does their involvement activity. It's really important that people are at the heart of actually deciding how to involve people and how we do it in the most effective and meaningful way. So we will be encouraging people to join a group that can shape the work of the Alliance in terms of their involvement activity. So, and we can share more with you about that as that develops. Natalie, could I ask you to click on, please? It's really an opportunity for you now to ask questions of us. Again, if there's anything that you'd like to ask us, if there's anything that's not clear, or we can answer or take comments. Anybody have anything that they'd like to ask?
Yes, I would, please. Do you have literature that we've got our AGM fast approaching in July, and it would be ideal if we could have some literature to give out to our members?
Very happy to do that, Chris. Yes, we have a leaflet that we could send through to you if that's helpful. That's either, hard copy or electronic, whichever works for you.
Yeah, okay, fine, thanks.
Thank you. Is there anything else from anyone?
I did just want to add that the links that are being shared in the chat box, we will sort of like make sure that people have access to those as well, not just within this webinar, but we'll sort of like share them when we share the link to the webinar. So there's lots of great links in there, but there's also been quite a lot of information. So also, if that's okay, I will share the slides with people afterwards as well.
And I've just noticed that Claire's joined us. Claire Vincent is the project manager for Communities Against Cancer. So if you'd like to ask any in-depth questions of Claire, I'm sure she'd be very happy to answer them. Tez, would you go to ask?
I just wanted to say, I can't remember who said it, was either Richard or Nigel, but prehabilitation, I love that, and I'm going to be using that. I hope I don't have to pay you any royalties for that, but I will definitely be using that in my marketing ideas. I think it's really good. Guys guys like that prevention side of things and taking control of the situation themselves. And so prehabilitation, I think, is a great idea.
Yeah, and I think actually it's sort of when someone gets a diagnosis of cancer, they feel that their sort of whole world has changed and their world is controlling them and them not controlling their world. Yeah. And if you feel that even if there's a small area that you can take control of, and in those few weeks as you wait to start treatment, you're taking more exercise and eating a healthy diet, yeah, that actually makes you feel better, yeah, as well as actually making a difference to your condition as you start treatment.
And I think for all health rates, I mean, public health is all about prevention. I think, you know, prevention is much better than cure. So yeah, prehabilitation, I think it just works for everything basically. So yeah, Chris and Eric, you'll be hearing me using that phrase quite a lot in future. Thank you.
I wonder whether if Richard, whether you know much about SafeFit, which is obviously if somebody's had a cancer diagnosis, but is an opportunity for people to get support to get physically better, isn't it? And perhaps we could find the link for that.
Yeah,
so
yeah,
again,
we
to pass on.
Have a look at that. And actually, even following on from treatment, we now know the impact of exercise and diet in terms of preventing recurrence. So, for instance, there's very good data for both bowel cancer, breast cancer, and prostate cancer that regular exercise reduces your rate of recurrence. We're not completely sure as to the mechanism of that, but it's looking very encouraging. And Cancer Research UK have some quite major research studies going on looking at the full impact and the full data of that.
Could I just ask a question to you, Dr. Roope, about the significance of 1960, if you're born after 1960?
I think that's just data that's they're looking at those born since that time. And I think it's just an arbitrary number they've picked out of the one of the things, particularly with cancer, which Nigel alluded to, but the phrase that we use quite widely to explain the rising incidence of cancer, and that is that we're now living long enough to develop cancer. So whereas previous generations would have succumbed either to infection or cardiovascular disease, because the advances we've made in both heart disease and stroke prevention, relatively few people are now dying at a young age from heart disease and strokes.
Thank you.
Can I just comment? When I was diagnosed with non-Hodgkin's lymphoma, I went to the consultant for the first time, and they wanted to give me all these leaflets, informations and links and things. And rightly or wrongly, I said no to the whole lot, because it was just my thought that I would read through all this stuff and worry.
Yeah.
I wouldn't know what relates to me or what doesn't. And I'd just prefer to, if things happen, to turn up and ask somebody. But I think that's where I found the peace. I mean, I do also exercise quite a bit, so I take your points that exercise is very important. But the mind, I think, also anything to reduce stress, to have the peace to live with a cancer, whether it's going to kill you or not, was for me, I think, a great healer.
Yeah, yeah. And actually, there's very good data coming through now that's looking at the whole area of sort of life behaviours, that it's never too late to get the benefit of adopting a healthy lifestyle and behaviours. So even if you've had a life of wreck and ruin, it's not too late to change. And there's some really interesting stuff coming through from I don't know if any of you sign into the COVID app, where you log your symptoms on a daily basis. That's run by a very charismatic professor of epidemiology, Tim Spector, who's done a lot of work on the gut microbiome. And we're gradually getting more and more data on the impact that has on all areas of health, including cancer, both in terms of prevention, but also living with and beyond cancer.
And talking about COVID, I just had a thought, like how much has COVID impacted on people actually attending or getting their cancer screening? I mean, do we have some catch-up work to do?
We have serious catch-up work to do. So we think that there are currently about 45,000 undiagnosed cancers that would normally have come forward through the COVID months. So if we compare pre-March 2020 with the past sort of 15, 16 months, we know that a huge number of patients have stayed at home and have taken to heart the mantra of save the NHS, stay at home. So if gentlemen and ladies have symptoms that they think are not quite right, now is the time to engage with the GP teams to see if it's something that needs evaluating further.
Can I just add about Communities Against Cancer? Sorry, my video's not working. I'm Claire and I work on the Communities Against Cancer project, and that's what it's all about, is that improving early diagnosis and helping people understand those messages and when to go to the doctor. So if the gentlemen here today feel like they would like to have these conversations with the people that they work with or are within their community, then please get in touch and talk some more about how we can help you have some of those conversations. And as Sue said, we also have grants available along the South Coast that can help if you need some funding to help you do that.
I was also going to pick up on Eric's point about the reducing stress. The Alliance has quite a lot of work that's going on around making sure people get the right psychological support for them when they are diagnosed with cancer and having their treatment as well. So where people need that support, the team are looking at how best to provide it and making sure that it suits people in the right way. So there is work going on in that area too, if you're unable to manage that yourself.
So, I mean, we are running out of time now. It's time for maybe one last comment or question, if anyone wants to pip in before I sort of thank everybody and close down the meeting.
Yeah, I think my sort of final comment would be that we just need to talk cancer, that it's not the fear that we once had in many cases. And certainly if you have an early cancer or a late cancer, you're so much better getting support and treatment early rather than just letting it fester and develop further. So we want to hear from you. And if you think you might have something of concern, get on the phone or get on the keyboard.
Thank you, Dr. Roope. I think we might actually have to quote you on that in some of our communications. So thank you everybody for coming. Thank you to Dr. Roope and to Dr. Watson for your really engaging conversation about cancer. If I was a man, I'd be signing up to get my prostate checked straight away. Also, thank you to Sue and Claire for sort of talking about some of the other ways to get involved. I will be sharing all of those links with more people as well. I hope this conversation that we've had today can really help alleviate some of those worries people might have about getting tested for cancer. I know lots of people stress that they might have cancer, but they're too scared to find out if they have cancer because then it makes everything much worse. So hopefully this conversation will really help sort of like make people realize that, like you said, it's not the scary thing that it used to be. And some of those, the positive finding, the positive rates through the cancer screening will also, I think, help people just get screened as well. Thank you very much for being part of this webinar. We will share it with the Men's Activity Network and the Hampshire Community Champions programs. So people have access to the information through those networks as well. I hope it's been an informative Mental Health Week. Mental health is also obviously an issue every day of every week, not just in this week. So we will sort of like keep on banging the drum over the rest of the year as well. Thank you again, and I hope to see people again soon.
Great to be with you. Bye.
Thank you. Bye-bye. Thanks for coming.
Bye-bye. Thank you.
Bye.